tract emergencies, because we're still in the abdominal cavity, can we get that presentation back up again? And then what we're going to do after this session, we turn to urinary tract, then Ellie and I are going to talk about 2 case scenarios. We're going to talk about a problem case in the urinary tract, and then we're going to talk about a problem case with the gastrointestinal tract. And we've selected GDV. Is that something that everyone here sees? Yeah, okay. So we're going to spend almost an hour, about 50 minutes on the GDV, but I want to go through urinary tract now to complete that abdominal cavity, and then we're going to give you a case example where we're going to talk from different perspectives. So important to recognise, we talked on day 1 about developing competencies. Now, one of the competencies you need for GIT surgery is an airtight, watertight seal, being able to close a viscous with an airtight, watertight seal. And so when it comes to the urinary tract, if you've developed your skills on the GIT, you should be able to transfer those quite readily across to urinary surgery. Few differences though. So similarities is that most of the organs we're dealing with in the urinary tract are hollow organs, much like the GIT. You've got to make sure that you maintain patency. So again, we've got all those same considerations. The closure techniques have to provide an airtight, watertight seal, no leakage. Both tissues are delicate, and the strength holding layer is the submucosa. Why? Because that's where the collagen is. So remembering that outer muscle layer, it's a bit like the abdominal wall. That's not got much strength. Serosa is a single layer, and the mucosa is like mush. It's got no holding power. So all of the strength in both these tissues sits where the collagen sits, in the submucosa. Now, the differences between the urinary tract and the gastrointestinal tract are that some components of the urinary tract are duplicated. This is really nice because now we have an option of removal as a treatment option. You don't have that in the GIT where everything's singular. But there are components of the urinary tract, so particularly the ureter and the urethra, that are particularly small, significantly smaller than anything in the GIT. So we're going to need a new subset of skills if we want to operate on these tinier structures. Same principles, but new competency in terms of the skill. In terms of the organ which is most closely related to the GIT, I would say that's the bladder. And so if we're talking about developing skills, I think the bladder is a good place to start. I think the stomach and the small intestine are a good place to start. So if you are relatively inexperienced, then again, the bladder heals very quickly and it has a very similar feel to the GIT. So in terms of what I want to talk to you about, I think at least in my practice, these are probably the most common. I hope it's similar to what you would see. But obstructive disease would be one, so stones in particular, and then urine leakage or urabdomen. So they'll be the 2 scenarios I want to talk about today. So obstructive disease, again, similar to the GIT, it can present with a variety of different signs. And the reason for that is, again, just like the gastrointestinal tract, obstruction can occur at any level, and it could be partial or complete, could be intermittent even. And so again, the signs can be highly variable depending on the nature of the obstruction. So the signs could be asymptomatic. Some dogs have bladder stones and have no clinical symptoms, but yet some animals have complete obstruction of the urethra, and this is life-threatening. So the signs can vary widely. And again, the obstruction can occur anywhere from that renal pelvis all the way down to the tip of the urethra. So we need to learn how we can image all those areas. This is not my area of expertise, but it's something that you need to be aware of because of the important role that the urinary system plays in metabolism and also body homeostasis. Obstruction will cause potentially very severe derangements in your body function. So common changes that we see here include post-renal azotemia, hyperkalemia, hyperphosphatemia. But again, every case is a little bit different because of the nature of obstruction: full, partial, acute, chronic, location. So the most common causes of obstruction, the ones that I want to focus on, are the uroliths, so particularly in the ureter, the bladder, and the urethra. It's a bit beyond the scope of our talk today to discuss all the neoplasia, herniation, but these are all things that can also cause obstruction. But uroliths, again, can be found anywhere in the system because they form when you essentially have too much of the salts in your urine, and you get sedimentation and then aggregation of all these sediments to form these little stones, and we name them based on their location. So they're nephroliths if they're in the kidneys, they're ureteroliths if they're in the urethra, and so on and so forth. So this is not uncommon to see on radiographs, signs of nephroliths. This tells me this animal is prone to stone formation. Doesn't necessarily tell me that this animal is unwell. So many of these animals are completely asymptomatic because the renal pelvis is quite big. It's a bit like a gastric foreign body. They can sit there, they exist, but they may not cause signs. They may be the cause of hematuria. They may be the cause of recurrent infections. But generally, we'll try and manage these medically. So, although most of these are calcium oxalate, many of these can pass, but they'll be very painful and they risk obstructing further down the path. Now, calcium oxalate can't be medically dissolved, but they can pass. And although it's tempting to say that these may be the cause of pain or discomfort, rarely are they clinically a major problem when they're in that renal pelvis. So we can try and get them to pass. You can use lithotripsy to try and break them down, but that's not widely available. Or you can look at surgical removal. Now, this is something that in days gone by was suggested as an important step to take, but now we recognise that going surgically to remove these small nephroliths is likely to cause much more damage to the renal function than benefit. So it's not generally recommended. Okay. Now, the next area down where we get blockages, so in the ureters, this is a real area of interest now because we're recognising that ureteral obstructions are really quite common and they can be really debilitating. And so often the problem is we don't recognise the early signs of obstruction in the ureters. Why? Because you've got 2 kidneys and 2 ureters. So if you get obstruction on one side, you won't pick up changes because the other kidney is functioning perfectly normally. So where you might see signs is just simply pain. An animal goes off colour, is unwell, is extremely painful in the abdominal cavity, is probably the first sign. More commonly, we see them when they're actually azotemic or uremic and they've got renal dysfunction. The reason for that is it's now affecting the second side. So often the first side we don't see. The second side is when they've lost their functional reserve. So we often see this phenomenon of big kidney, little kidney syndrome. We'll talk about that in a moment. So most of these stones are calcium oxalate, and we can diagnose them generally on plain radiographs. But this big kidney, little kidney syndrome is particularly important because if the ureterolith is on the size of the little kidney, that's probably ancient history. That's probably been obstructed a long time ago. The kidney shriveled up and died. You can work all day on that side, but you've missed the boat because that little kidney shriveled up probably has very little function. Where you need to take action is if you've got a ureterolith on the side of the big kidney and the other side is little, because this means you've got all your eggs in one basket now. That big hypertrophied kidney got bigger because the little one got obstructed and shrunk. Now you're on your second side. This is your last chance. These are the animals that are often unwell because now they've got renal insufficiency. Now, obstruction of these and relief of that obstruction is indicated, but I do want to let you know that any of the techniques to try and relieve that obstruction are generally technically more demanding. They're generally technically more difficult and require additional training. And there is training available for all of these different procedures. So this is a cat that presented to us. I got called in actually in the middle of the night. I showed you this radiograph because of the normal peristalsis, and the clinician was concerned this cat was painful and that it had a linear foreign body. Didn't have a linear foreign body. That's normal peristalsis, that look of the intestine there. But you may notice there's 2 little opacities right up here, like this. See these? Now, you could be mistaken for thinking perhaps they're in the colon. And so to be sure, we take an additional view. We can see now these are not in the colon. So when we saw this, well, it became apparent that this was likely to be a ureteral obstruction. The animal was mildly azotemic. We ultrasounded that kidney and then injected a small amount of contrast directly into the renal pelvis. At the same time, we aspirated some of that urine for culture and sensitivity. What you could see here with this contrast study is that there is only a partial obstruction. So that's good news for this kidney. It gives us a little bit more time. We can medically manage this, and that's what we did in this cat. 48 hours on fluids, repeat the imaging, nothing had moved. So what do we do now? Well, how we approached this case was slightly different to how I would approach it now, because this was about 15 or even more than 15 years ago now, where there wasn't many options apart from surgery. So in this case here, we went in surgically. Here we can see, here's the ureter and this is the stone here. To operate on the ureter, you often need magnification. And so this is through the operating microscope. You can see the suture up the top is 5-0. So they're just stay sutures holding the fat back. You may see a continuous suture line just here. And this is 9-0 suture material here. So that's closure of that ureter. But this is done under an operating microscope. It's technically difficult. If it's distended, it's quite possible, but leakage is the biggest problem here. And so outcomes after this surgery were variable. Sometimes we get good results, sometimes we don't. And so the next step along was stenting. So could you, and even minimally invasively or through open surgery, put a tube from the renal pelvis into the bladder to bypass that blockage? And that was done for a number of years. But of course, these animals, particularly cats, are stone formers. So they would get incrustation of this stent and blockage of the stent. So what was recognised is the need to flush that. And it's very hard to do if it's all within the abdominal cavity. And so that led to the development of this subcutaneous ureteral bypass system. And so this is a system where we have one end of a catheter in the renal pelvis, and then it comes out into a tube to a little port. And that port is important because it allows you to flush the system so it doesn't get blocked. And then the other end goes into the bladder. So it's simply a tube. It's like an artificial ureter to take urine from the kidney down into the bladder. So it's just the plumbing problem. And so it's been evolved over a number of years, but this is a radiograph from a case we did recently where you can see that pigtail catheter sits within that big kidney. You can see the size of it. You can see that this has now evolved. This is called sub 3.0. And what it does, rather than having the port in line, it has a little Y adapter. And the port just sits as an extension on the outside, and we flush into that little port there. And about every 3 to 6 months, these cats come back for a check, and we check to make sure that everything is patent and flowing. So that's a subcutaneous ureteral bypass. This is now considered the standard of care for ureteral obstructions. Has anyone had experience with a sub at all? No. So I would suggest that within probably the next 10 years, it will become very common practice within India. It's very expensive, the set, and it's only produced by one company currently. But again, technically, it requires a little bit of additional training. I went on the course twice because it's quite hard to do. So additional training is very useful if you're going to start. But I've no doubt this will be coming soon. When it comes to cystic calculi, these are really common, so stones within the bladder. And again, if they're not obstructed, these animals can just present for recurrent urinary tract infections or hematuria. So again, if you've got recurrent urinary tract infections, you want to rule out cystic calculi as a potential underlying cause. Now, radiographs will identify a number of stones, but not all stones are radio opaque, and so you won't pick them all up. Sometimes ultrasound, sometimes there are so many stones you can palpate them in the caudal abdomen. And so there are some stones which can be medically dissolved. The really hard thing is often when these animals present, you don't have the stone in your hand to get analysed to know what sort of stone it is. And it can be a little bit deceptive if you run a urinalysis. Crystals may not be the same as the stones, the composition of the stones, but there are some that can be medically managed. When it comes to removing them surgically, and in many cases for my medicine colleagues who are often referred these cases for medical dissolving, they feel that our best chance is often to remove them and then start with a clean slate. So remove those stones, get them analysed, and then change the diet and lifestyle appropriately. So we're commonly doing cystotomies, and from an anatomical point of view, recognise that all the vital structures come in dorsally. So the vascular supply, the nerves, the ureters, they're all coming in dorsally. there was a period where it was recommended that we retroflex the bladder and we went in dorsally. The thought being that you didn't want any sort of sediment sitting on your suture line. Now that's been debunked, and what we know is that it is safe to perform a dorsal or a ventral cystotomy. Either are appropriate, complication rates are similar between the two. And so if you've got a choice, I would always go ventrally. And I would always go ventrally because one, it's easier, and two, our incision is away from all those vital structures. So I place 3 stay sutures here, one at the apex, one on the either side of my proposed incision. When I make my incision here, and you can see those stones within the bladder here, what I then am looking at is the dorsal aspect of the inside of the bladder. So if I want to catheterize the ureters, I could do that very easily, and I'm not going to catch them in my closure because there is the potential, if you're doing a dorsal cystotomy, that you inadvertently capture one of those ureters as they're coming in. The other thing that helps me here is if I'm not retroflexing it, then I can see all the way down the trigone and down the proximal urethra. Because if I'm so I'm retroflexing it back, then the bottom of the bladder goes down a deep dark hole. There's an easy way to leave stones behind if you're going to remove them. So I would always go ventral. We know that it is perfectly safe and there are fewer complications or equivalent complications if you go as compared to going traditionally that dorsal approach. So go ventrally. Again, we want to minimize our tissue handling. We're going to be hunting around potentially for some time looking for all these stones. So rather than having retractors or fingers or instruments on that, use stay sutures. Passing a very fine suture through the tissues causes minimal trauma, but it gives you a very secure way to mobilize and hold tissues. So we're going to place 3 stay sutures in. So this is my setup here, packed out that abdomen again, remembering probably even more importantly than with the gastrointestinal tract, you want to minimize contamination with the urinary tract because the risk of this being infected urine is much greater. There's stones in there. Often, again, the stones lead to irritation. They increase the likelihood of infection. And so there is a greater risk that you've got contaminated urine that's going to flood into your field. So I always have suction at the ready, and then I pack this out. So I want to have any leakage hit those lap sponges rather than go into the abdominal cavity. My stay sutures are in place here. I use a sharp scalpel blade and I make my incision into the bladder. This is actually how I perform the removal. I have my suction tip in there to clear away urine, and then I use forceps to retrieve those. Now this is one place that I will use the dressing forceps because they're flat. I'm not worried about crushing a stone. You can use them to pick the stones out of the bladder. So when you get in there, some people use a sterile spoon. I often just use forceps here. I always have a urinary catheter in because by having a big urinary catheter in there, then it means that I'm not going to have stones finding their way down the urethra, but it also means I can flush. So once I've removed everything I can see, I get them to withdraw the urinary catheter. So this is an assistant. This person you have to be very nice to because they have a horrible job. They're often under the drapes like this with a syringe and that urinary catheter, and they're pulling it back slowly. I get them to pull it back bit by bit and flush and flush and flush. So therefore, if there is a stone in the urethra, I'm going to flush that back into the bladder and I can retrieve it. So I put my suction tip cranially. And you can see here that cranial stay suture has gone lax because I'm using my suction tip to hold that bladder further cranial. It means what I'm looking at down the hole is the trigone, and I'm looking with all the fluid coming up from the urethra back into the bladder. I've then poised at the ready with my forceps, so when something shoots out like this, I can just pick it up and take it out. And I repeat this for probably 5 minutes or so. Flushing, 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 retrograde, back from the outside to the inside. Eventually, your assistant pulls out that catheter altogether, and then I'm happy that I've flushed everything in that right direction. But that's not enough. What I then do is I get a catheter and I flush back the other way, from the inside out, because there is a high likelihood of leaving stones behind if you're not thorough with your flushing. So I start with flushing that indwelling urinary catheter into the bladder, and then at the end I want to flush out. And it's incredible what happens when you remove those drapes and you have a little look. Often there's lots of little bits of sediment that you've flushed out that way. So I want to flush, and my final flush is from the inside out. But in some studies, like this study by Grant, 20% of cases had residual stones. That's frightening. 1 in 5 cases, stones were left in. So keep that in mind. You cannot flush enough. Sterile saline is all you need. And then when it comes to closure, this is the really pleasing news. Look at this graph here. The bladder of all tissues in the body heals the fastest, essentially full strength by 3 weeks. So it's a good tissue to heal. So that's very pleasing. I like to use PDS rather than monocryl. Now what we do know is that in infected urine, these will dissolve faster than if you don't have infected urine. At this stage, often we don't know if it's infected or not, so I generally use PDS. I try and minimize the amount of suture that goes into the lumen. The reality is it's very hard to perform this closure where you don't go into the lumen. The textbooks say don't put the suture into the lumen, but I would rather put a suture material into the lumen than to miss the strength holding layer and have dehiscence. So minimize the amount, but make sure that you get that submucosa. Generally 3/0 or 4/0 suture material is what I'll use, but it depends on the thickness of the bladder here. Now again, 2x2 rule if the bladder is normal, but if the bladder is very thick, you may be able to space them out a little bit further. So up to sort of even 3, maybe even 4 millimeters apart, but it depends on how thick that bladder wall is. You can leak test that. It's a little bit harder because everything wants to go down the urethra, and then I omentalize it. Whenever I omentalize either the intestine or the bladder, I don't tack it down. I simply put it on top, and look at all those ends, those little ears of suture. It's like Velcro. The omentum won't fall off it, and even if it falls off it, if the body needs it, it'll put the omentum there. So you don't have to do any additional tacking. And then we always take post-operative radiographs to make sure that we've removed them all. And so make sure you get everything around the urethra, so you don't want to just get abdominal, particularly in a male dog, remembering the urethra runs caudally. So there are a few alternatives here, and we can use endoscopic or lap-assisted procedures here. I don't do a lot of this because, as you can see, they're still reasonably open. So urethralis, they're much common in the males because of the longer urethra. And in dogs, the areas where we see blockage is around the ischial arch and then also just caudal to the os penis. So this is where they often will bank up. Now, the urethra is narrow, it's thin-walled, it's small, and it's surrounded by cavernous vascular tissue. Do not operate on this area unless you absolutely have to. Ideally, what you want to do is to flush them back into the bladder. So you don't want to operate on the urethra unless absolutely necessary. Retrograde hydropulsion is ideal, and then you can do a cystotomy. So I like to think of this as not being a process where you're actually pushing them back in. If you try and push stones back in, it's highly likely you'll tear the urethra. You want to flush them back in. So it's hydropulsion. So a bit like a plunger, you want to build up force and push them back into the bladder. This way you won't damage the urethra. Some little tips and tricks I have for you is if you mix sterile water-based lubricant with saline, 50-50 mix, it makes your flushing solution more viscous. It will drag those stones back in rather than flushing with saline alone. So the easiest way to do it is you get half a syringe of each of those, you put a 3-way tap, and then you mix them like this. And that will create a more viscous solution. In the male, what I tend to do is have an assistant put their finger in per rectum and push down to occlude the lumen of the urethra. So this allows you to build up pressure when you're flushing, and then you get them to episodically release that, and you're more likely to get them flushed back. I would say in the vast majority, 95% of cases at least, you can flush them back into the bladder. Then you do your cystotomy as we discussed. If you can't, then you may be forced to do a urethrostomy, and this is where we're either going to make a temporary or a permanent incision into that urethra and remove those stones. Bleeding is the real side effect with these, and again, I would say this probably fits more into an advanced technique, because they will bleed a lot, and you need perfect apposition if you're doing it permanently of the mucosa to the skin. And it's the same with cats and the feline perineal urethrostomy. This is, we give about an hour lecture on this procedure, so it's beyond the scope today to talk about a perineal urethrostomy, but again, it's very much technique related to get no tension and to get mucosa to skin apposition. So in summary, urinary tract obstruction can occur at any level. Surgery at any other site other than the bladder is challenging, and you probably want advanced training if you're going to do that. Most urethrolyths can be flushed back into the bladder, so then you can just do a straightforward cystotomy. And my tip when you're doing cystotomy is go ventral and make sure you flush, both retrograde and normograde. Flush and flush to make sure you don't leave any stones behind. And then closure to ensure an airtight, watertight seal. So I've got 5 minutes now to talk about leakage. What happens when we have a leakage from this closed system? Most commonly I see this with trauma, but again, there are other possibilities here. So depending on where you get your leakage, you'll see different signs. So if it's the kidneys or the ureters, you may get retroperitoneal accumulation of fluid. If it's the bladder, proximal urethra, it might be a true urabdomen. If it's a distal urethra, you might see tissue necrosis. So again, it's not always a urabdomen that you see. To diagnose this, often you'll see, first of all, free abdominal fluid. That'll be your first take. Now, that could be ultrasound, it could be radiographs, it could be palpation. These animals are often unwell if they've got a urabdomen, so they'll be vomiting, they may look shocky, and again, these signs are generally mildly progressive at first, but then they tend to get worse. So often, these animals are not particularly unwell straight after it's happened, it's slightly delayed. So if you see free abdominal fluid of any type, then sampling that can be very useful. If the creatinine level within that abdominal fluid is higher than the level you're seeing in serum, then it's highly suspicious that you've got a urabdomen. Urea is not as accurate because urea is small, so urea can equilibrate from the abdominal space to the serum. Creatinine is a very big molecule, so it gets trapped in the abdominal cavity. These ratios here just are the cutoff marks to be 100% sure, but if your creatinine in the abdominal fluid is higher than serum, then you should be very suspicious that's urine. You can also use potassium as well. So to determine if it's occurred, you're going to need some form of contrast study. If you think it's proximal, then an excretory urogram, so giving intravenous contrast agents that are then excreted through the kidneys, so you want to make sure kidney function is appropriate. This is best for imaging if there's any damage to the kidneys or the ureters. If you're worried that it's more bladder or below, and this is the most common, then I would do a retrograde urethrocystogram. So this is where you place a catheter in the urethra and you inject contrast. Normally sterile iohexol, for instance, is what I would use in this case. And you may see here that you get very small amounts of leakage, or they can be very large amounts of leakage, and that determines how we treat them. So if it's a ureter or kidney, generally it's surgery. Unless you have advanced techniques, it's generally removal of that kidney, so a nephrectomy. When it comes to the bladder, this is most common, particularly after trauma, and these ones are very treatable. So if it's a very small leak up the top here, and every time you do a cystocentesis, you will get a bit of leakage. You may just place an indwelling urinary catheter and give it a little bit of time to seal on its own. But if you're seeing, like the bottom here, actual leakage on these radiographs, then you will need to go in surgically. Don't rush in. You need to stabilise your patient first, but equally don't wait too long because you'll never completely stabilise that patient because this is the underlying problem that you've got urine leakage, and until you address that, it doesn't completely normalise. So you want to get them as stable as possible. And then when I go in again, this is like very repetitive, but you can see I've got my Balfour retractors, I've got my lap sponges to pack everything out, minimise my contamination. When you get in there, it may not look spectacular. Often you see, omentum over the top of it, and it doesn't look, particularly spectacular. You can pull that off, and then here you can see there's a whole lot of slightly necrotic-looking tissue just through here. So this looks a little bit frightening here, but generally that's just the edges. And so here I've got my forceps in, and they're just inside the bladder here, and you can see the tissue around there. It's like just having any other traumatic injury. The tissue is somewhat damaged. And this is what it looks like after we've trimmed the edges. So again, just with my well-maintained Metz and Balm scissors, then I'm trimming those edges off here, and you can see this is what I'll take off until I'm back to healthy looking wall. And once I've got healthy looking wall, then we close it just like a cystotomy. So again, the same principles as what we spoke about with tissue injury and a large open wound. We want to debride. In this case, we can't treat it as an open wound, so we need to debride, close, and then account for any potential ongoing effusions. Now, this is just a case that was a urethral tear, and in this cat, you can see the damage here is outside the abdominal cavity because it's a urethra, it's not bladder. And this was a very challenging case. A catheter couldn't be passed. And so in this case here, we've gone in and done a laparotomy, and we've passed the catheter from the cystotomy site from the inside out. So this is the cat's tail here towards the left here. This is the penis. And you can see we've placed the catheter in through the bladder, and it's coming out through the tip of the penis. Now, interestingly, for those cases that you can't catheterize from the outside in, often you can catheterize them from the inside out. So after that, what we do is place a little guide wire through that catheter here. So then it connects the two, and then we simply place a second urinary catheter on that guide wire, and then we can place it and slide that up and into place like this. So the additional step is that you do have to do a cystotomy, but the advantage here is you can divert that urine until that urethral tear has healed. And generally we don't suture the urethra, we just divert the urine until that's healed itself. And there are other ways to divert urine for small tears. So you can use cystostomy tubes or these pigtail catheters. So in many cases, we let the body do the heavy lifting here. You don't have to try and microanastomose a cat urethra. Diversion is often the way to go. So in summary, leakage from the urinary tract is most common after trauma or potentially after trauma from us, particularly traumatic catheterization. Clinical signs of urinary tract leakage vary depending on the location. Metabolic derangements are very common, so you need to recognize that and stabilize your patient. And then the treatment may involve removal of an organ if it's very proximal, like the kidney. It may involve primary repair, for instance, if it's the bladder. Or it may involve diversion, particularly if it's urethra and not a complete transection. So complete transections you have to suture, but if it's just a tear, as we most commonly see with traumatic catheterization, then again, that can be treated with diversion. All right, thank you very much. It's my last lecture, and I just wanted to say how thankful I am to be here today.